Great, and I want to thank everybody for coming to a great session. I think we got a cast of all-star speakers here today. Social media, I think, is a bit of an unknown right now in a lot of spaces, so we thought this would be a nice session to get people introduced to social media and different ways and ideas of how people are using social media in the setting of education, patient care, that type of thing, and for departments. So I'd like to bring up our first speaker, Elliott Fishman. Elliott, I think I probably follow his page more than any other page on Facebook. I learn about renal artery stenosis, even though I'm a neuroradiologist, and certainly all the New York Times posts that he has. But he's got a great, CT is Us has got a huge presence on Facebook and on the App Store, and I thought there would be probably fewer people better than have Elliott come up and just talk about what it all means and give us a basic overview. So thank you so much, Elliott, for joining us. Appreciate it.
Thanks. Okay, let's see here. It's a pleasure to be here. I guess I have 30 minutes, so I can hit start. Okay, great. So what I'll do in this talk is sort of be kind of two parts. Tell you a little bit about where things are, and I'll sort of tell you what we do, more not to kind of explain what we do, but kind of to explain why it's possible and some of the things we've learned and some of the successes and some of the challenges. There's no doubt social media in healthcare is big, and I think everybody recognizes that, surely everybody in this room. If you go back even 3 years, this was a lead article in Fortune magazine basically speaking about the opportunity for changing how things are done, this idea of an online global community for patients with the same disease, finding a doctor based on reviews, and offering something that many other apps don't do, which is literally possibly saving your life. So there's a lot of interest in that going back a number of years. Now, what I'll try to do is I'll try to do the Yogi Berra thing, not so much to tell you the theory of things, but kind of tell you sort of what the practice really is. And there was a second good quote I found from Warren Buffett. Well, it may be all right in practice, but it'll never work in theory. So I'm going to stay away from the theories and leave that to somebody else some other day and just really focus on sort of what we think indeed works. If you look at social media, there's a lot of definitions, right? I think everyone has their own definition. Everyone kind of in their mind knows what it is, but it's really this whole way of sharing information to people everywhere and anywhere, not knowing who your audience is or what they're thinking about. And it really is a different way of communicating. It's no longer that one-to-one or a teacher sitting in front of a class or an audience, but it's really this sort of infinite opportunity to provide information or get information from a number of different sources. It's interesting, medicine in general probably is way behind a lot of the other fields in terms of social media. And surely radiology probably is not at the forefront of that as well. A good article by Eric Granser this past year speaks about how a large number of colleagues really are not aware of the possibilities and the usefulness of social media. Now, if you try to think about what social media is, and I'm not going to cover every one of these things, of course, it really is many different things. So whether it's networking, you can see the names you all recognize, or it's blogs or microblogs or things like Twitter, which come back and forth. There are so many different ideas and areas that people can use, and these continue to grow. And we'll talk about the most popular ones, and surely the ones that we have the most experience with. There's no doubt that the trend of social media only grows. I was in a talk down the hall, and someone said, how many people have a mobile device with them? And of course, it's everybody. Everybody has a phone or an iPad or 3 devices with them. If you look at just mobile devices, the smartphone user base is now over 2 billion. More than half the world's people are carrying phones. And again, the numbers continue to increase, right? So basically, everybody from age 11 or so seems to have access to the web. And if you look at healthcare in general, there was an article published looking from the Pew Research Center looking at what smartphone users do, and more than half of them actually use their smartphone for health information. And in fact, people look more for health information than they do online banking or anything else. So healthcare really is something that affects everybody, but it's something where people expect that their connectivity is really going to help them. And you know, big companies like Apple, which follow trends or maybe lead trends, recognize this, because if you look where Apple is going, whether it's on their mobile devices, from the iPad to the phone to their watches, basically the focus is on healthcare. When Tim Cook spoke on March 21st introducing the new phone and the new iPad, a lot of what he focused on was healthcare. That and the FBI, of course, but healthcare was probably more important than the FBI. Then if you think about what we do as radiologists, and if you look at patients, you know, patients really want social media as a way of thinking about how they do things. Patients are no longer willing to have medicine practiced, as has been for a number of years. They want access to medical records and imaging records and information about their disease and outcomes, but they also want access to physicians, and we are physicians as well. So the ability to really deal with people becomes something that also is really defined within social media, because it's something people expect, and it's something, because they expect it, we need to do. And in a sense, it's going to impact how we deliver things, right? So this increased desire for interaction with radiologists and information in general, whether it's a second opinion or just the fact they're comfortable with that first opinion, really means we need to be there in some form. And again, that's a question of how to do it, but it's something we really have no choice about. And there was an article, as the JSCR, Whitney Zember wrote about social media and personal health, making the point that it's not a great surprise, because everything else everybody uses today for information is on social media. So it would be illogical to think that healthcare would be any different. And healthcare, as we said, becomes extremely important. What's important for us, I think, in the radiology perspective, is to recognize that we need to be upfront and leading the charge, because I think at the end of the day, there are many different websites and many different specialties kind of going to patients. And unless we become one of those trusted sites of information, we're potentially going to be left behind. So I think it's very important, surely in that personal space, that we are leaders in information. This whole idea about trusted networks, and this is a quote from that article, but the thing about trusted networks is very important, that people, you know, all of us, you look at certain websites for your mail, you look at certain websites for information, for your medical advice, radiology, but there are infinite sites out there. And once you have comfort with the site, you tend to stay there. So I think radiology has the danger, unless we have sites that really do meet people's needs, we can be left behind. And other specialties like surgery has been very aggressive, medicine in parts have been very aggressive. We could be left behind as something, as sort of a have-not perhaps. And it's a real danger. There's an article by Gary Glazer. Gary was chair at Stanford, passed away a couple of years ago. Gary was a very, very smart guy and a great visionary, and he wrote this article about the Invisible Radiologist that basically focused on the fact that most people don't know what a radiologist is. 1 in 2 people still don't know what a radiologist is, whether we do the scans or read the scans, and most people still think their own internal medicine guy reads the scans. And Gary did a second article that made the point, which followed the first one, that because of that, in great sense, there was a decrease in the prestige of radiology, that many people felt that radiology was more of a commodity than a science. And that, again, would have great impact on us, not only with the public, but with medical students and the like, and payers, if commodities never get paid very well. Now, it's been a challenge for radiology, I think, for many decades, those issues, but I think social media really gives us a second chance to rebrand ourselves, because we've always had the issue of not being upfront and personal with patients. Certain areas, interventional, mammography perhaps, ultrasound a bit, you do touch the patients, but in general, when you're reading a stack of CTs or MRs, you're not near the patients. On the other hand, social media will really allow us to redefine ourselves. What is radiology? What do we do? What are our exams? How do we help their health care? And why it was so important. If you think about it, in terms of a patient being in the hospital, they see a number of different specialists perhaps, but all of them see radiology, I think, an average of 4 times. So we actually aren't a commodity, we're the prime player. One can look at it as that everybody else is the commodity. There was an article by this Eric Reinhardt talking about social media and did make the point that one of the many things it can do is this visibility among clinicians and patients. So it really is an opportunity for us that really needs to be really done. There are many things we can do, and it lists many of the different things, but I think the one that's very important in this regard is this visibility issue. And it's not just in the U.S., this is in England, talking about the national health system, talking about healthcare workers to utilize and embrace social media for the benefits of staff, patients, and their families. So it is something that's not a U.S. thing, it's really a worldwide idea. Now, in many ways, we are doing things. I was involved for the past 9 years with radiologyinfo.org. How many people know about radiologyinfo.org? Okay, a number of people. Well, you're all supporting it, whether you raised your hand or not. It's from the ACR and RSNA. It's really well done. It's basically designed only for patients. It's information for patients, the Radiology Information Resource for Patients, RSNA ACR. It covers all of the diseases, is written for patients, it's not written for radiologists. It explains the diseases, it talks about treatments and talks about diagnosis and talks about every imaging modality we do. There's going to be 200 videos which explain in 60 to 90 seconds what a study is and what people could expect. So it's a really good look. And the good thing about it is we redid the site about a year and a half ago, and now the site gets over 1 million hits a month. So that's very important. So it's a really good way of us putting our best foot forward. And there are many different things in terms of what patients do see. There's a site called Cancer Commons, and it's a non-for-profit site. It's actually run by a person who had a cancer, was told they were going to die in 6 months. They went online. They found a different therapy that was experimental from the NIH. They were treated, and 10 years ago, they're still alive. This site's interesting because it addresses patients' questions about cancer. It doesn't sell anything, but it leads them to various trials, has all the information on every trial going on, and you could put your information in there. It says 100,000 papers are published annually on cancer, 50,000 clinical trials, or at clinicaltrials.gov. It streamlines everything for you. You put your information in, what disease you have, and basically tells you the options. So again, addressing patients' concerns, and that site's been very successful. We had speakers at Hopkins speaking about how to use social media in healthcare. Bill Phillips is the editor of Men's Health magazine, which has 20 million users. And he was talking about what people expect, from their magazine, but people expect to be upfront and personal about their healthcare. And his thought was that the reason, in terms of hospitals don't do very well is because patients, the goal is never to come to a hospital. It's to keep in good health before. But also the fact that they directly interact with their users. And he felt that, based on what we told him, that radiology doesn't really interact with our users. And so that's a real challenge for us going forward, that people want to take charge of their health. We need to be helping them along to do that. So there is opportunity, and we can learn a lot from other fields that do well. If I look at social media, it's really a way of changing how we do things. And I mentioned patient care and patient education, but it's really all of education and training and teaching, from the residents to the technologists to CME. And also it's an important way, and I think it's going to become an important way, of really looking at how we do research, whether it's patient recruitment, follow-up, or multi-institutional trials. So if I said to you, you want to get started doing social media, I think in thinking about it, you really want to think about what's your mission, perhaps what's your intended audience, what information do you want to put out there, and perhaps what's your budget. I think at the end of the day, the goal tends to be the same, right? You're trying to figure out some way of increasing connectivity between your team and the outside world. You have some goals, perhaps, of information you want to get out there. The question is, how do you go about doing it? When you look at the different sites, I mentioned I showed you a slide that had like 30 things, and I could have showed you a slide that had 100. The three ones that we tend to favor, and most people favor, are Facebook, Twitter, and YouTube. LinkedIn is always number 3, in fact, in terms of numbers, but it's a little bit different. That's on a professional level, so I'm not really going to cover LinkedIn. And there are a number of different articles. This I copied yesterday, so I did my talk yesterday, or changed all the slides yesterday, perhaps. The top 10 sites, which I can just zoom up on: Facebook, Twitter, LinkedIn, Pinterest, and Google+. That's simply based on numbers. And you realize that Facebook dwarfs everything. 1.1 billion monthly visitors. Twitter is next with 310,000. So in the social media sites, Facebook really is the big dog, which I think all of us recognize. So how did we get involved with social media? That's a good question. We've done CT as Us now for 15 years. How many people have been to CT as Us? Okay, a bunch of people. So CT as Us is a website we did, which started with CT protocols. Now it's actually the largest content website in the world in medicine, in terms of images, lectures, and the like. And so we have lectures and teaching files. We have 226,000 cases of all different types. And you can see cardiac there says there's 12 million visitors looking at it. And we have that. We have things from monthly quizzes to pearls to journal clubs to medical illustrations. We have about 850 lectures. And so we had this web thing, which I think was pretty good. But then as social media came along, we felt perhaps could we connect with our users a little bit differently? Where CT as Us really, there's nothing very humorous on CT as Us. There's cases, there's images, there's text. There's nothing very personal. It's really just pure content, I think done well, but it's really pure content. So we thought perhaps maybe we could address the audience differently, and you can see on the left side. So we decided to do the go look at the web. We also at the same time develop apps. We have 10 apps on the Apple Store. So we kind of spread our bets. We have 10 apps on the Apple Store, about 250,000 downloads. But we said, let's do social media. So we started with Facebook, since that seemed to be the logical place to do. And we've done this for about, I would say, 4 years now. And it's kind of interesting. With the Facebook, what we tried to do was figure out, could we have a more friendly face to our audience and perhaps build our audience, maybe bring them back to CT as Us. Now, in saying this, there's no conflict of interest because we neither charge anything nor sell anything. So it's a really good business model. It's incredibly good. You know, business has never been better. If you look at what we do and what we put online, so we did not want to do what you do on a website alone. So we did not want to just put up a bunch of cases or lectures. So what do we post? Well, here's a screenshot from yesterday, and Vice President Biden and Mike Bloomberg were at Hopkins giving with his cancer thing on immunology. Bloomberg gave $125 million. So we had an article about that, perhaps. We had an article from the Harvard Business Review. But we post the classic radiology thing. We post a case of a day. Usually it's with an audio every day, 4 a.m. East Coast time. We have that. And you can see, if you look really hard, this was posted within 6 hours. 12,621 people looked at it. And then we post a Pearl of the Day, which is some interesting fact from an article, something we wrote. And you can see here's a different day, another case, and here's 10,000. So the average case gets about 20,000 within 48 hours. The average Pearl is probably about 5,000 to 7,000. We then put up radiology factoids. So we take material. You know, what we tried to do, if you think about it for a second, you know, the Beatles released a new album last year, which is really good since two of the Beatles are dead, and the Beatles last recorded 35 years ago. So in some sense, you can reuse content. So we had articles we wrote about aortic arch formation, and so we put those online, and you can see there within a day it's 14,000 people. Information of interest. The Bloomberg thing is kind of interesting because it was Biden speaking about cancer, and you can see 10,000 people within a couple hours. In some sense, material isn't part random because it's things I read. So we're combining the imaging with things that are happening in the world. So whether it's a good TED Talk or it's this medical illustration we put up, whether it's last night when I was traveling, I saw that Julie Dreyfus is going to be on SNL as the guest host in April. We put that up, and in about an hour, there were 15,000 plus people I don't care about Russell Crowe, but Julie Dreyfus means that probably Steinfeld and Larry David will show up. Or it was Eric Clapton's birthday the other day, so we had Eric Clapton performing from last year. If you look at our numbers, it's somewhat impressive. We have 1.2 million people using it a month. So we have no money for advertising, but we've gotten up to 1.2 million. Men are the largest audience. Mobile devices, 86%. Videos, that month, 300,000 people look at our videos. Again, it's depending on how many videos I put up. And you can see when you look at the charts, and all of these numbers come out of Facebook. Facebook gives you online statistics. We get between 200 and 400,000 users every day. And it's interesting, if you said, where are the users from? Now, this chart's a bit hard to see, perhaps, but you see U.S. is number one. But that's only about 25% of what we have. India, Pakistan, Egypt, Brazil, Mexico, Iraq, Saudi Arabia, Philippines, Bangladesh. Okay, number one city is Cairo. I probably wouldn't go to Cairo these days. Dhaka, Karachi, I can't even pronounce these cities. It takes you to hit a U.S. city, which is either New York or Houston, it takes you about 30 different lines. And you can see, I mean, it's amazing the places you go. It's 190 countries, 192 usually, we get to. So it's amazing your reach. And if you look at if you do a pie chart, only a quarter of it is U.S., so 3/4 is worldwide. It's amazing how many places your information gets to without you trying to get it there. And then if you look at things you post, we posted a CTA runoff. That's a video. 377,000 people it reached, 38,000 views. I mean, you could see this just in a month. Those are our biggest hits. I mean, think about you're doing education and you're worrying about 10 people looking at something. I can have 400,000 people look at something without trying very hard. And then you say, well, you have no money. Can you compete? I'm very big on numbers and I'm very competitive. On Facebook, you can put down other sites. If you want to be depressed, put down Taylor Swift. She has 72 million. So if you want to feel like you're a rounding error, just put Taylor Swift on top. But I put Hopkins on top. When we started, I had the ACR and RSNA. So we were at 3,000. They were at 55,000. This is just likes. Now, likes are better the longer you've been around. Once people like you, as long as they don't unlike you, you're good. But now, this is the other day, we're at 83,700, and ACR is 72,000, and RSNA is 67,000. So you could dwarf. So our engagements is a factor of 5 more than RSNA or ACR, and a factor of 3 combining RSNA, ACR, and Renkenray. We can with 3 times that on a daily basis. So you don't need to have a big organization to be relatively successful. And these are the numbers. So it is somewhat impressive. Again, if you're not charging anything, it doesn't matter, but it makes you feel good. You can look at those numbers. We just published this article in JACR, and one of the things you really look at is Facebook being an educational tool is what this article spoke about. And what we realize is a lot of people look at the information because it's quick, it's easy, it's fast. Facebook is pushed at you. One of the reasons Facebook is so successful and Twitter is not. Twitter, you have to search for information in some sense. Facebook comes right at you. And so Facebook is really number one in terms of education in that regard. So it's tremendous opportunity there. We do Twitter as well. And basically, we were doing a lot of special stuff on Twitter. We have Twitter now attached to Facebook. So whenever we post something on Facebook, it goes over to Twitter. And we get 83,000 users in a 28-day period. So you do have some impact there, though I think Twitter is not as strong in medicine. And we do YouTube, 1.5 million views. All of our lectures and videos are on YouTube. They're also all on the Apple Store. On the Apple Store, there's 30,000 people download a month. And here's about 5,800 subscribers and 1.5 million views. So, again, it's easy to reach on YouTube, and so everything is kind of sitting within YouTube. And the fact is we're reorganizing it because our videos are now over 3,000. And YouTube works well. Remember, YouTube is part of Google, and so everything is for free for the user and for the developer. And it's cross-platform, which makes your life indeed very easy. Now, it's interesting in terms of, the academic side of things. You can use social media to recruit patients. There was an article by Schumacher talking about a rare disease, Fontaine-associated protein-losing enteropathy. They spent years recruiting a handful of patients. Then they recruited patients online, and they got 671 respondents. Okay, 76 were successful, majority in the U.S., but they recruited almost all of their patients via Facebook. It was very impressive. Social media referred 84% of all respondents. So it was very cheap, very easy, and very quick. And if you look at things like in the newspaper, when talking about the Zika virus, everything was on social media. It wasn't in newspapers or journal articles. And from an academic perspective and a patient care perspective, we can be out there publicizing our screening studies or patient safety initiatives and get that information out to the patients. And there's no doubt it's not just radiology. The WHO, CDC are all using Facebook and YouTube as a way of getting their information out to the patients because they realize with a couple tweets or a couple postings, you can reach all of the patients within hours or minutes, which you could never reach them before by sending things in the mail or putting them in the newspaper. It's interesting, this whole social media affects our practices in ways you don't think about. How many people know what Yelp is? Yelp.com. Few people. Yelp is this thing you go look at if you want to go to a restaurant and see if people like the restaurant. Well, there was an article, Rosenkrantz and the guys at NYU wrote this article about looking at Yelp to see if patients were reporting perceptions about imaging centers. And sure enough, they were. They were saying whether they liked the imaging center or not, positive and negative response. And they also found that what people liked most was the service. They really didn't care about the radiologist doing good or not good. They didn't even know that. They wanted good service. So I said, okay, I'm at Hopkins, #1 hospital or #2, depending the year you look. We must be incredible on Yelp. So I looked, our average is 3. 5 stars. I happen to know what it takes to be a top-notch hospital. This one's 5 stars. Kudos to all of them. Or Catherine. I cannot understand when anyone have a bad experience at Hopkins. I had complicated surgeries. Dr. Eckhauser, who is incredible, by the way, I know, incredible, just retired, unfortunately. Loved him. But then 1 star. You know, when you get 3 stars average, that means you have 5 and a 1. Hopkins is great if you're desperate. Okay, that's not really good. I have never spoken to more people, been transferred from line to line, waited longer on hold to get a doctor's appointment. It took me a month to get through. Not very good. So, you're going to find out a lot about your practices that you really don't know or perhaps should know. Now, the question is, how many of you are doing stuff on social media now by show of hands? Okay, a few people. So the question is, people think about it a lot. Should I wait? There is a first mover advantage, so waiting is not a good thing. Those trusted networks will be built before you get involved. And the thing is, things will continue to change. So it's not like waiting for the perfect time because there will never be a perfect time, and it's not a textbook. You learn and you change. We're constantly changing. We talk about this integration. You look at the next generation of people coming along. It's really integrated into the lives of millennials, and millennials are the med students and the residents and the people you're hiring to work for you, and that's how they expect to get material. So it's totally changing. So you need to really be there. The millennial generation favors more technologically oriented teaching methods, web-based delivery, and this will only grow as the popularity and the availability increases. So there are challenges doing these things. One is that you have to do it 7 days a week. You can't say, I'm on vacation for 2 weeks, I'm not going to be posting. Content is king, so you need content. If you don't have good content, no one's going to look at your site. Someone needs to take responsibility. On my Facebook page, I do 100% of the postings. So I can't criticize someone else for posting the wrong thing. It does cost time and money, and time is money. And it's hard to make revenue, being realistic. Everything seems to be free in this world. And then one can ask, is it really part of your core mission? You have to really think about your core mission in that regard. If you look at articles, there's an article by Kim in the JACR as well, talking about how many apps there are and talking about some of the challenges, including the fact that apps are often not good and there's lots of dissatisfaction. So if you're going to do something, you have to do it well. Even if you get started and it's small, it needs to be done well. If people have a bad experience, they're never going to come back. It's kind of like a restaurant. You open a restaurant and you go in for a meal and the meal's bad, you're never going to give them a second chance. So you really need to be careful on how you're designing this stuff. You also need to know what can go wrong. Institutional policies. We don't get involved with patients, okay? At Hopkins, the institution wants to deal with patients, so I don't deal anything with patients. It could take a lot of your time, which it does. It's always challenging, I think, a little bit as perhaps things are changing. How do you get academic credit? I'm a professor, so they can't promote me anymore, so I don't have to worry about academic credit. But it is a challenge with junior people when it's not peer-reviewed. It's very, very hard to explain when I write promotion letters, how that works. And you need some sort of long-term strategy, but I never really worry about long-term strategy because it's too much to think about. You need to be careful. Again, we all know about inappropriate postings and the like. For example, I don't post anything about the election. I don't know who I like, who the candidates even are. The only thing I post about the election is what I see on SNL. And if it's on SNL, that's fine. If you have Donald Trump on SNL, if you have Hillary on SNL, and if you have Bernie and you have Larry David, that's great. But I don't post anything about anything else happening, what Trump says or Hillary says or Bernie says. I don't bother with that. I think it's exciting. I think the possibilities, you're looking about this idea about getting information out there. I think if we don't do it, it's going to be a real challenge for radiology because everybody else is doing it now. And again, it's not easy and it's not a perfect trip. That quote from J.R. Tolkien about not all those who wander are lost. I think if you get involved in social media, it is a little bit of surfing. It's not really clear exactly where things are going or how they're going to change over time. I think they will change over time, but I think at the end of the day, you really need to be in the game. I think that what our goal is to kind of be at every level and then worry about it later. But I think if you worry too much about being perfect, then you end up doing nothing. And I think doing nothing is probably the biggest problem. So with that, I'll thank you for your attention. Should I take any questions? Or any questions from anybody? Yeah.
What is your local institutional policy regarding social media and your involvement? Because I know you said different institutions have different requirements. And I'm wondering what is legal to flourish.
Yeah, our policy is don't post anything inappropriate. It's kind of like a generic policy like that. I also don't represent the institution. There's nothing on there that says Hopkins. When Bill Brody was president of Hopkins, when I started the website, he said, just do it on yourself. Don't worry about Hopkins. He says, if you worry about Hopkins, you're going to spend 15 years arguing about the color background. So basically, what I've done is, if you look at our website also, it does not say Johns Hopkins. I just do it because the second you have to ask, there's a million people who want to control everything. So this way, we just do it. We're very careful about not putting anything inappropriate, but we're not really worrying about the hierarchy of things. So basically, the way the question about content, the way I look at social media and the way I look at the web in general is like writing a textbook. You can write a textbook. The one thing that really works out well when you're not charging anything, it's really very hard because your conflicts of interest disappear. Now, if I did say, let's say I decided I'm going to sell this for $1 trillion or something, Hopkins does have a formula, so if you want. And in fact, actually the biggest problem I do get is from the president of the university, who's a good friend of mine, who wants us to sell because every university is looking to make money. But if no money is changing hands, it's very simple because you have no conflict of interest, and the mission of Hopkins is education. So, yeah. Well, the thing is, no, they don't say anything about that. The thing is, I think it's always a dual-edged sword. The second you start putting an institution's name on things, besides if you write a textbook, you could put down Professor of Radiology, Johns Hopkins, Tufts, wherever you are. They don't endorse that textbook. They don't know if it's any good or not. But you own your title. You can put your title in any brochure or anything. But that's not an endorsement. But I think what happens is, you know, all institutions have bureaucracies. You know, you look at big institutions, they have 30 people doing their website. And then everyone wants control, even though they don't know why. So I just look at it, this is a resource we do for education. And that's our, you know, one of our mission. That's how I go beyond it. Our mission is education and training and teaching. It's like writing a textbook. So I really don't, I don't ask too many questions, basically.
How many times a day do you post content?
A lot. So I happen to know our average posts a week about 125. So a lot of stuff I do, like, for example, the cases. Every day we have a case. I'll post 2 weeks at a time because you can go into Facebook. But then, you know, I'll do, and then, like, I'll know I'm lecturing right now or I'll be traveling tonight, so I'll post a bunch of things I read that'll show up. But half of it is you got to post what people find out. So if you go to today's post, the biggest thing that happened in the world today while you're sitting here at this incredible meeting is that Taylor Swift did an Apple ad. Okay, you got to watch it. It's really good. You know, it's really good. But, you know, so you really have to, you can't be posting that tomorrow. You need to be there today. You can't be like the 800th person to show that thing. And you have to be also topical. Like today, for example, the first Mac was introduced in 1976, right? So you want to be on top of that. There's also the great article which they posted. You know, when Steve Jobs was fired from Apple, he was pissed off. Never do anything when you're pissed off. He was pissed off he sold all their stock that he owned. Do you know how much Steve Jobs' stock would be worth today if he didn't sell that? $66 billion. Now, when he passed away, he left about $25 billion, so it wasn't so bad to begin with. But you want to, you need to have information that's timely because people, you know, you look at the site, right? You don't want to see things about that. You don't want to find out that St. Louis won the World Series last year, or that was Kansas City. I'm sorry, whatever. Anything else? Yeah. You just kind of, you get good at it after a while. I mean, so what happens is now so people send me things. So even my kids send me, my daughter's, you know, my son works for the mayor in New York. My daughter works in New York. They send me information. Other people send tidbits to me. You know, we have a lot of speakers. People send me things, so I get that. And then I read a lot. I mean, I get up early. I stay up late. So you just do it. It's not that hard. Once you kind of build it into your routine, it's like you don't even notice you're doing it. I don't do it like when I'm reading CT. So if I'm reading CT, I'm between 7:30 and 5. I'm reading CTs. I don't stop and say, oh, gee, I need to post something. So days when I'm reading, you know, I'll just post stuff in advance and just fill in every 2 hours or something like that. The Facebook was much more difficult about 3 years ago in terms of posting. It was really hard to use the site. Now the site's very easy, so you can post a lot of things. I don't have other people post because since I'm responsible, someone can post something innocently that's inappropriate. So this way I don't have to have a discussion about what to post. I kind of know it's myself, and I'll just think about it a couple times for at least 5 seconds.
That was my question. Have you ever posted something you hadn't posted?
No, I think the thing is that, you know, if you stay away from anything that has to, I mean, like, for example, all this craziness in the world with ISIS, okay? The only thing I've posted is, you know, when the thing happened in France, you know, we were so sad for the people of France, or when it happened in Belgium, was so sad for those people, you know. So the human nature of things, you're never going to be sorry about. But I would never say, look at those crazy people doing this, that, and the other. So it's you just have to stay away from the bad side of things and really focus on the incredible things of what people do. So our focus is, like I said, the only thing at all you can say is controversial is SNL skits, you know, and I make sure there's no dirty words, you know, like I like Larry David, and he's very funny, but I listen to his clip very carefully that there's no F words, and so it's only benign. So you just want to make sure there's no slips. So you've got to make sure you look carefully at what you post, that it's not going to be a problem. So the biggest complaint we get is sometimes people don't like my selection of music. I tend to like, you know, Eric Clapton, you know, Taylor Swift. You know, sometimes people disagree with my selection, but other than that, no problem. Anything else? Okay, thank you very much.
Thanks so much, Elliott. That was great. Next, I'd like to bring up Rich Duzak, who's professor and vice chair of health policy at Emory University. Rich has been very active in social media in the last 3 years. A total of 30,000 tweets, 15,000 followers. Again, another guy who we wonder how he finds the time to do all this, which I'm sure we'll hear about. But I'd like to welcome Rich up. Thank you.
Thanks, Harp, and thanks, Lori, for inviting me. Thanks, everybody, for sticking around for Friday afternoon. It's always nice to see. It's always a little unnerving accepting a Friday afternoon at a meeting invitation, whether there's more speakers than there are attendees. So the title that was assigned to me is Social Media and How to Approach it from Your Department's Perspective. And I'm going to take a slightly different perspective on that because our departments are really all of us. And this is social media. It's not your communication or your PR media. So if you really want this to be social media, it's about getting everybody socialized in this process. And ultimately, a lot of the things that you'll hear from me will be very similar to some of the things that you did hear from Elliott, which is, you're really creating your brand. I mean, this is an opportunity for those of us who are in academics. I mean, at least for me, pivoting from private practice to academics a few years ago, we all like to hear have people listen to us. We all like to have people read what we're writing. And social media is really just a way to help get out there and sort of do an online eternal panel discussion and textbook here. And so some of my comments are really going to focus on the branding aspect of things. And I think this is increasingly important for us. Elliott picked up the Invisible Radiologist article. We're getting less invisible from a point of view of the patients. Most of us now are struggling with what do we do with these patient portals. Here's one of my portable chest x-ray reports, and I'm not sure whether a patient actually went into this or not. But, if you're like a smart consumer and you read this, chest x-ray report and you're looking in it, it's, you've got persistent but smaller likely loculated left pleural effusion. What are you going to do? You don't understand what all these words are in there, and you're going to go to man's best friend, which is Google, and you're going to type in pleural effusion. Probably the next thing a lot of patients are going to do is saying, well, who is this clown Duzak that did the interpretation? And they're going to type in my name or your name. So I actually went through the exercise, and I redacted it here. One of actually the best radiologists in my former private practice in Memphis put his name in there, just put in radiology because it was a sort of semi-common name, and came up with a zillion hits. And every single one of these hits was some commercial website that had sort of some garbage about him, nothing personal, no identification. He was a pure commodity on Google. Now, let's put in contrast that, and you could probably do the same with Elliott or other people who are active in social media. Type my name in Google. What do you find here? Basically, you're going to find top 10 things on the first page of Google, which is really 10 things on there, and every single piece of content in there is something that I control or my university controls or some organization I'm involved in controls there. So basically, my face on social media, on digital media, is what I want the world to see about me rather than what other people want the world to see about me here. And so I'm going to also quote Yogi Berra here. If you don't know where you're going, you might not get there. And a lot of this really becomes, how do you get, what do you want on that first page for you? Some of this is strategic planning, a lot of things in life. How do you plan to get promoted in a few years? How do you plan to do that startup company? How do you plan to, really leverage social media? You have to come up with a plan for some of this. And I think it's important when you think about that from a point of view of the reality of the world. This is some work that Arvind Vijayasarathi, who's one of our senior residents, will be presenting at the ACR meeting next month. And he worked with Tom Lofhelm, who's just a computer genius. And basically, we set up a bot that Googled every single radiologist in the Medicare database that's out there and pulled their top 10 Google search hits there. And I'll talk with you a little bit about that here. But if you look at basically the majority of hits for over 70% of radiologists are controlled by some third-party sites, and we know nothing about these. Only a minority of people, and I would argue that that's not what you want, right? That's the unhappy face of this garbage that's out there. The ones that you really want are the ones where you or your practice or your hospital controls it, because that's how you want the world to see you. And we should be thinking then about shifting from that third party to the first party from a point of view of control of media for ourselves and our digital presence. So there's a lot of pollution out there, and a lot of us as medical students or surgical residents remember the mantra, the solution to pollution is dilution, when we're irrigating out the abdomen in there. And, you know, I think the key piece here to think about is to ask yourself, how often do you go to the second page of a Google search? I mean, maybe when you're doing something scholarly and academic, but you know what, if I'm a tourist, I'm going to page 1, and I think I'm pretty typical there. Fewer than 10% of people will advance to page 2 when they're Google searching. And so when you talk to the marketing people out there, they say the best place to hide a dead body is page 2 of the Google search results here. So the goal here is that garbage, right? You want to hide those dead bodies. You want to bury that on page 2 there. How do you do that? Well, you dilute the pollution by creating your own content. And that's the opportunity that you have with social media to do the kind of stuff you've heard Elliott talk about, or the things that you'll hear me and Amy talk about, what we've done individually here. So what are your social media goals? I mean, if you really want to get out there, you know, Elliott's got some goals of what he wanted to do. I had some goals as well here. And here's some of my things here is, you know, a few years ago when I really got active on Twitter here, I was in a position, I was starting up the Neiman Health Policy Institute for the ACR. There's 1 million health policy institutes in the Washington, D.C. area. We wanted to distinguish our brand and get out there. We wanted to network with people. I was also transforming myself individually from private practice to academics, trying to brand myself. And so this is sort of an opportunity for me to sort of accelerate that, you know, curve that a lot of people have gone through a traditional route. My email box is overloaded with tons of content, RSNA news, ACR news, all this stuff. I unsubscribed to all of those. And all my content now comes to me curated through people whose opinions I respect and follow on Twitter. It's been an amazing opportunity to engage and collaborate, and I'll tell you a couple stories about that. And it's also fun if you're somebody like me or Elliott who were pathologically addicted to some of this stuff. So I'm going to walk you through, at least for Rich, what some of my social media use cases are. Not that these are right for you, but I think a lot of this is storytelling. If you say, aha, that's something that sort of lines up with what I want to do, that's a box that I may want to check for me. So I use Facebook very differently than CT is us. Facebook for me is my personal life. Everything else is professional here. So this is me being silly with my daughters at the World of Coke. I lock it down. The only people that can see anything on my Facebook site are people that are my trusted friends, or at least people I've acknowledged as friends there. And I've got a bunch of stuff. So all the political humor, the silliness and stuff like that I avoid professionally, that Elliott avoids as well out there, is the stuff that goes on there. This is my opportunity to connect with my buddies from high school, medical school, wherever out there. Family pictures. My in-laws came to visit. We went to an Emory basketball game here. You know, I make fun of my electric car. I call it coal power, just to remind people where electricity does come from. 40% in this country comes from coal. My hobby is tactical shooting there. It's not stuff you necessarily want to professionally put out there. But this is, you know, my buddies that do that stuff. They were really excited when they see, oh, my daughter went to the range with me, and we had a lot of fun doing that kind of stuff. YouTube's a great piece as well. There's a lot of things that we, as academic radiologists, get videoed for. And YouTube, which now, as Elliott indicated, is part of Google, you know, anytime you get that content, link it to your YouTube page out there. That's sort of how people can check you out if they're thinking about a potential speaker for their program. Actually, it's amazing, too, with the power of Google with some of these things. I headed up our ICD-10 transformation in our practice, had to educate all our physicians and all that kind of stuff. We had all these seminars, a few people we couldn't get to. So one of the webinars I did for our faculty after hours, I just taped and posted it on YouTube there. Didn't advertise it, didn't do anything. About 2 weeks later, I run into some guy at a Radiology Business Management Association meeting. He says, Rich, that video you did was great. I used it to train all 50 of our radiologists. Wow. And, you know, there were only 20 of our docs that I needed to get it to, but the pages had 126 hits. Now, there's not a lot of people Googling ICD-10 transformation radiology, but it's just stuff that's out there as well. LinkedIn, I sign up for it. I use it. I have a profile on it. I really don't use it for anything other than to accept people, just so I don't feel like I'm dissing them, you know, when I get all these invites that you probably get as well. I really don't use it for anything, but a lot of people in professional spaces do. You do want to be looking at these websites that are out there. There's companies like Vitals, Health Grades, all these people out there. Some of the information they have about you may be accurate, some may not. Some of them have opportunities. You can email them and correct it, that you don't have garbage. There's some of them, for example, Healthcare Review still has me listed as the practice I was in, 12 years ago in Pennsylvania there, and there's no email link. There's nobody there. I think they may have set it up, but this is stuff that's pollution until I dilute it down and get it onto page 2 of my site. Doximity is something, anybody subscribe to Doximity? I would encourage you, if you're not, to take a look at it. I have no financial interest in it, so it's Dr. Proximity is the name. They basically set it up to be sort of the LinkedIn for doctors. It's actually sort of cool because you can, basically upload your CV and somebody there will format it and set up your page for you. Sort of cool kind of stuff. Once you sign up for it, it connects you with people you overlap with residency practice. So, some of the clowns I went to medical school with, all of a sudden, hey, that's where he is. Those types of things was pretty cool to get connected with. It actually gets you a free fax machine, electronic one, because just for personal stuff. That's nice. But the most important thing about Doximity, if you go to U.S. News and World Report's doctor's website here, it's powered by Doximity. So that profile you set up by sending them in your CV, you controlling how you want the world to see you, is what goes on U.S. News and World Report's website about you. Once you do that, U.S. News has, pays money for Google search engine optimization. That immediately pops in within a few days to your top 10 there, and that's what patients start seeing about you, or other people start seeing about you, so you can correct your location information, all those types of things. And this is how you dilute out some of the pollution that's out there. Now, Twitter is like, crack for me. I'm just, 30,000, I'm almost up to 30,000 tweets. It's a lot of fun here. And it's the opportunity for me, like the stuff you heard from Elliott. I see interesting stuff. It gets out there. This is my soapbox. This is an opportunity to connect. You want to set up something pithy about yourself. I don't advertise it as Neiman Health Policy Institute. I don't advertise it as Emory. I'm a radiologist, discontent with the dark. And you can read what am I trying to do? Seeking ways to put the care back in healthcare. So something that's, hey, positive, nice doc. Now, there is a link to a website for people who want to learn more about me, and I'll talk with you about some of those. But it's been an amazing opportunity for me to connect. There's people like Matt Hawkins, who's speaking in one of the other rooms down the hall, one of our other faculty members, a lot of people in the department I connect with, a few deans of some medical schools that are just these random people I never would have met, but we have these conversations offline. It's been really cool. Eric Topol, is the editor of Medscape, good guy to connect with, just, really visionary, and you wind up having private messages with some of these people if you have good content. I've never met Matt Nielsen. He's a urologic oncologist at UNC. He and I actually connected through social media, wound up emailing, calling. We're actually working on a project together with one of his former residents who's a urologic oncologist in London, doing some health services research related to some utilization trends in urology. So, amazing opportunities out there. Reporters are out there. There's health safety people, good people to be in the good graces of, because, these people, you either want to be nice to them or you're one of those mean doctors that are out there. Sully Sullenberger, the Miracle of the Hudson dude, followed me one day. This is like really cool, and you have these conversations with these people. So it's actually pretty fun kind of stuff once you're out there. Now, people, you can't just set up Twitter and all of a sudden these people are going to follow you. You have to, like Elliott, create some content. The tool that I use is Buffer. I think it's great. It's basically, I do a lot of my reading in the morning, wake up at 4 in the morning, read just sort of everything off the web. But who's on Twitter at 4 in the morning other than maybe Rich and Elliott that are out there? So I put it into Buffer. It's pretty cool. It's got a little interface, and you do this, and basically it says, okay, I'm going to tweet out 8 times a day at these peak times when your followers are likely to be online that's out there. So there's always content. I actually looked, something just randomly tweeted out while I was sitting there paying attention to Elliott's lecture. I didn't tweet it out. Buffer did it for me there. Make sure that your web page and on your university site and your practice is set up and done well. Information that you can customize there. A lot of these things get set up in plain vanilla format, so if you can control it, that gets into your top 10 as well. If you're involved in any societies or organizations, again, for me, half my life is through the Neiman Health Policy Institute. Another opportunity to just dilute out the pollution that's out there. There are some personal stuff, so this is sort of how I, at least for me, that works, that I'm not branding this as university content. There's something called about.me, which is okay. that a lot of people use. It's easy to set up. I actually found this a couple weeks ago, flavors.me, $20 a year. It's pretty cool. It allows you to sort of put pictures in and do all sorts of stuff. And I actually have duzak.info point to it. So it's the information about me with hot links that take people back to our university and other sites as well. Just a little bit of the networking there. And so if you want to sort of set up a website for yourself somewhat individually from what your university has, take a look, and there's a number of other companies that are out there. So everybody's homework assignment after some of this stuff is to Google yourself, see what your top 10 looks like. Some people have done that. From the work that we've done, 30,601 radiologists are in the Medicare database. 30,600 of them have an online presence, so you likely do. Make sure you know what it looks like. Now, this, of course, begs a question here. Which was the first question I asked, is who's this one person? Does anybody know Dr. Robert Rippner in Edgejik, Alaska? Okay, so he is the one, and this is how we set up the bot, basically. It pulled your name, added an MD radiologist in your town of your practice to sort of filter out a lot of the trash there. So nobody knows where Robert is, poor Dr. Rippner. We will be taking up a collection to send out a dog sled party for him, although, pretty much everything gets out there on social media, so I think this is probably more likely where the guy is here. So one radiologist here. So in summary here, first impressions, like your mother told you back when you were in kindergarten, are lasting. And how most people make first impressions of us as radiologists is digitally. So you need to be thinking about that. Natural does abhor a vacuum. There are a lot of these companies out there that are polluting your brand, whether you like it or not. And so the solution to pollution is going to be page one dilution. And again, whether you like it or not, you've got an online identity, and you either own it or somebody else owns it. And it's actually not too hard to do this kind of stuff if you just do it step by step and become persistent in the process. Thanks for your attention.
Thanks, Rich. That was great. I'd like to bring up Amy next. She's an assistant professor at Mayo Clinic, neuroradiologist, and has quite a presence in social media and using social media to help connect with patients and other physicians. Thank you so much for joining us.
Thank you. Thank you, Harp and Lori, for inviting me to give this talk. It's quite an honor to follow two social media luminaries, Elliott Fishman and Rich Duzak. So I'm honored to be here. I'm going to talk a little bit about how we can use social media in education. I'll talk about some social media platforms that I think are particularly useful for education, talk a little bit about how to protect patient information if you're going to do this, and then tips for incorporating social media into your educational programs. So, as we've already discussed, the millennial generation already spends a lot of time on social media. So those who were born after the year of 1980, they're already on social media. A recent study showed that 96% of students with internet access use social media every single day. And 3 out of 5 use social media to discuss educational topics. So young people are already using social media for education, whether we're there or not. I think it's really important for us to go to where our audience is, and they're on social media. The younger generation favors technology over traditional media. They don't want to pick up a book and read it. They want to go online. They want to go to their social media accounts, and they expect to be entertained. They've been using this stuff for their whole lives, and so they expect you to interact with them in the way that they have interacted with other tools in the past. Social media really requires relatively minimal resources. You don't need a whole lot of money to get started in social media. Mostly you need time, as we've talked about. Social media has a global reach. You can give a talk in a lecture like this, and there's 50 or 100 people. On social media, you can reach thousands, hundreds of thousands, potentially millions of people. Facebook, as Elliott mentioned, is the #1 site. There's 1 billion daily active users worldwide. Twitter is second with 320 million monthly active users. That's really powerful stuff. That's really a great way to get your message out to a large audience. And you can reach multiple different kinds of audiences. So we can reach our radiology residents and fellows. We can reach medical students who may be interested in radiology or who may be interested in going to other specialties and start to influence them. We can reach out to other healthcare providers to provide information about what it is we do and how we can help patients. And then increasingly, we can engage with patients and their families and provide information to them that's helpful in their care, as Elliott mentioned. And then you can use content, the content that you create, on multiple platforms. So you may create content for Facebook, you can post it on Twitter, Instagram, etc. I wanted to take a minute to talk a little bit about the social media lingo, because those of you who may not have used a lot of social media may not understand all of the terminology that we use up here on the stage. So fans or followers are people who subscribe to your content. They're people who come to your page, they like it, they will have that content delivered to their social media account every single day. Views are the number of people who have looked at a post. So it doesn't mean that they've interacted with the post in any way, just that it came through their feed. Likes or favorites are a connection to a post. So something that somebody saw, they actually took an action to click the like or the favorite button, which indicates that they have a greater interest in what you've posted than a view. And then a share is a repost of content that a user sees to their own fans or followers. So if I see something that I like on a social media account and I think that other people who follow me would be interested in it, I would post it to my page. And that will boost the number of people overall who will see the content. A reach is the number of people who have potentially seen a page or a post. So that includes all of your fans or followers on your page, plus all of the fans and followers of those who have reposted content. So it can exponentially increase the number of engagements that you get. And engagement, finally, is the collective number of views, likes, and shares that your posts get. And that's really what you're looking for when you're using social media. So engaging your audience is really going to be the key to your success. And we all know that from our traditional use of educational tools. It's true for social media as well. So Elliott showed a list of a whole bunch of different social media platforms. This is also not comprehensive. As he mentioned, Facebook, Twitter, and LinkedIn are the top three. The others are a little less common, but are still widely used. I'm going to talk about 5 different platforms that are widely used in radiology education. I'll talk about Facebook, Twitter, Instagram, because it's a photo or image sharing site, and YouTube. The 3 sites that I have listed on the right-hand side are sites that are targeted towards medical professionals, and I'll talk about Figure 1 because that's the one that I think is most relevant to radiology education. So we'll start with Facebook pages. Facebook, as you all know, leads the market in social media, with 50% of all social media visits in the U.S. being to a Facebook page. Facebook has a massive user base. It allows you to post images, videos, text, and links, so things that are all really key in radiology education. It allows users to make comments, so there is a level of interactivity between those who are posting and your audience. And then you can use tools like Facebook Insights to measure how successful you're being. And I'll talk a little bit more about Dr. Fishman's CT is Us Facebook page, because they recently published a study in JACR about this. So as he mentioned, he's had the website since 1999, and they launched their Facebook page in 2013. And then when they did this study in 2015, they found that they had over 11,000 fans from more than 40 countries. As he mentioned, only a quarter of the fans to their Facebook page or to his Facebook page come from the United States. The rest come from all over the world. The vast majority of fans were less than 34 years of age. So really, if you want to attract a younger audience, this is the place that you need to be. As he found in his study, images had the greatest reach. But videos had greater engagement, meaning that people interacted with the videos, they clicked on them. And that is pretty comparable to studies that have been done with other Facebook pages and with other social media sites like Twitter. Images attract a lot of attention, but may not have the same level of engagement that other types of content do. He found that the peak times to engage are between 10 a.m. and 3 p.m. Eastern Time. Obviously, the peak time for you may be different depending on where you're based. If you're based here on the West Coast, it will be Pacific time probably, but the middle of the day is really the time that most people are online and looking at content, regardless of the medium. Now, we've talked a lot this afternoon about publicly available social media websites. And one thing that I want to call everybody's attention to on Facebook is what's called Facebook groups. And Facebook groups are actually private groups. They're not public. They're smaller groups, and they're usually composed of people that have shared interests. Anyone can create a Facebook group, and then you can invite the audience that you want to your group by inviting individual members. And then only members that you have invited are allowed to view or post the content. There may be some women in the room that are part of the Radiology Chicks Facebook group. That's a private group that only members can belong to. And it started with a handful of women, and it's grown to over 1,700. So we all have a shared interest. We can all post there. But because it's private and only those members that are invited to the page can see the content, it allows much greater privacy. So if you have concerns about sharing things publicly, this is a really good option to consider. I'll move on to Twitter, which also has a massive user base. One of the key features of Twitter is that the content length is limited to 140 characters. As a result, there's a much greater reliance for those who use Twitter on linking to traditional websites or other social media. Radiopedia is very active on Twitter, posting content. They'll post these cases, they'll show an image, and they'll say, what is the likely diagnosis? It gives you an opportunity to think about what the diagnosis is before you click on the link, to see the answer, and to see a full explanation of the findings. Twitter is also searchable via hashtags. So you see the hashtag, it's a metadata tag that will allow you to search any content that uses that hashtag. The Radiopedia folks use the free open access medicine and radiology hashtag. If you want to see who else is posting using that hashtag, you can type that into the Twitter search bar, and you can find content that other users have posted as well. There are advanced analytic tools that allow you to measure your success on Twitter as well. You can use Twitter Advanced Search. Many people use third-party tools. At Mayo Clinic, we use something called Sprinkler to post, which allows us to measure our success on both Facebook and on Twitter. I pulled this morning from Simpler, and this is an analysis of the hashtag AUR16 meeting, and you can see that over the course of just this week, there have been 680 tweets by 126 participants for just under 1.5 million impressions. So a lot has been going on at this meeting using Twitter. Moving on to Instagram. Instagram is an image sharing platform, and one of the advantages that many people find with Instagram over Twitter is that it allows for a really lengthy caption, so you can put a great deal of detail about the image findings into the cases that you post on Instagram. It is also searchable via hashtags, and what many people will do will be they'll post their case on Instagram and then they'll link it to Twitter so that you can reach multiple users on different sites. Instagram also allows user comments, so users can provide feedback, ask questions, etc. Figure One is an image sharing platform that's very similar to Instagram, except for it's really dedicated to medical cases. Figure One claims to have 500,000 healthcare professionals active on their site, and it does have a process whereby you submit you apply for a page on the site using your institutional email address, and they will verify that you are in fact a healthcare professional, a radiologist, or that you are a healthcare organization or hospital. They have some in-app tools to assist in removal of patient identifying information. And they also have a team of moderators that will verify that removal of PHI has occurred. So they will look at every case and make sure that you don't have anything there that could be potentially identifiable. So that gives an extra backup to ensure that you haven't posted anything that could be controversial or cause a problem. And then, as been mentioned before, YouTube is another site that allows you to post full-length video content. You can post a whole lecture. You can post a series of lectures. One of my colleagues at Mayo posted a series of lectures about interpreting chest radiographs, so a series of 3 or 4 minute videos that you can watch anytime. So I did want to talk a little bit about protecting patient health information. I have some headlines out of the news. Doctors' X-ray postings unsettling. When Facebook goes to the hospital, patients may suffer. Employees' web post triggers injury. Tea Party candidate radiologist caught posting grisly X-rays with callous comments online. And then finally, CNA put nasty photo of patient on Facebook. The woman was fired and could lose her license. So you have to be careful with what you post, and you want to make sure that you don't post anything that could be potentially identifiable. Someone asked a question about institutional guidelines and policies. My employer, Mayo Clinic, has extensive social media guidelines posted on our intranet for employees. These guidelines apply whether you're posting things to your personal account or whether you're posting something to an institutional account, whether you're posting something on your own site or commenting on someone else's site. So I encourage everyone to look for and be familiar with your own institutional guidelines and policies. If they don't have anything specifically related to social media, you still want to follow any guidelines that they would publish for any type of content that you would publish, whether it be in a journal, a book, or elsewhere. Make sure you remove all patient identifying information from the images, so certainly all names and all medical record numbers, but you want to make sure that you don't post any other details that could be used to identify the patient. So don't post, here's a great case of X that came in through our ED on Saturday night, because somebody's neighbor could see that and say, hey, I know that so-and-so was in the ED on Saturday night, this could be him. If you have a truly unique case that you want to post, you may want to consider getting informed consent from the patient or the family before you do so. Many journals are now requiring that for case reports. I think it is something to consider if you're really posting something unique. So just to wrap up, some tips to get started if you want to try to use social media for education. As has been mentioned before, you really need to identify your audience and your goals. Do you want to reach out to medical students? Do you want to focus on radiology trainees? Are you really targeting referring providers or patients? Make sure that you understand what your goal is and who your target audience is before you start. You also want to determine how frequently you'll be able to post new content. One of my colleagues at Mayo Clinic, Liazy, who is pretty well known in healthcare social media circles, said having a Twitter or a Facebook page is like having a puppy. You have to take care of it every single day. You can't forget about it for a week and expect it to still be alive when you come back. So you want to make sure that you're going to have the time to do that and that you're going to have the content to do that. We've all put together teaching case conferences. It takes time to get the cases together. You want to make sure that you're able to do that before you undertake using social media for education as well. I suggest you start with one social media site, Facebook, Twitter, Instagram, whichever one you prefer. And then as you grow your audience and build your content, you can expand and you can start using multiple sites to reinforce posts and to reach a greater audience. Use multimedia, use images, use video, use text, and use humor. You want to be entertaining because that's really what the audience is going to expect. Make sure you post de-identified images and content, nothing that could be identified. And then you want to measure your success. You want to use the tools that are available to see if you're reaching your audience or if you've reached an unexpected audience and what kind of content folks are really interested in so that you can build on that as you go forward in the future. So that's all I have. Thank you very much. Are there any questions?
Why don't we take, let's take about 10 minutes for questions, and then we'll move into the next.
I have a question. Like a puppy,
So I think that there's a couple of ways you can do it. As Dr. Fishman said, he posts all of the content to his site, so I would imagine he can't ever take a vacation, or he will schedule posts to occur while he is on a vacation. Alternatively, what you can do is you can use a team approach, and you can make sure that you have several individuals that are going to determine what content is going to be posted and will be available to cover for each other when you're on vacation. So that's what we do at Mayo with our Mayo Radiology Twitter account. We have a few physicians that are involved, as well as we have somebody from the Mayo Clinic Public Relations team that works with us part-time to help post content on our site as well. So we have a whole group of individuals that post content to make sure that there are things going on all the time.
Our next speaker is David Sarkany. He's the program director at Staten Island University and a body imager. David recently completed a master's in health professions education, and he's going to be doing his session on feedback. So welcome. Thank you so much for joining us.
So thank you very much to Lori and Harp for allowing me to speak. We're going to be talking about constructive versus destructive feedback with respect to your medical students or your residents, so it's a little bit break from the social media. I have no disclosures. And I just want to start off, I mean, most of us can probably remember a time when we were called, or a friend of ours was called into the principal's office or program director's office, and things like, I can't believe you shouted out in class. This is your 5th time. You didn't raise your hand. What were you, raised in a barn? Or you ran across the street without looking. You're 14 years old. What kind of person are you? Or more applicable to something that we may come across with our residents is, you told the emergency room what? You really honestly thought that was appendicitis? So things like that are things that happen often. So the objectives of this talk is to define the difference between constructive versus destructive feedback, discuss the short-term and long-term effects of feedback, and identify ways to provide feedback, constructive feedback. So something that I kind of looked at on my own and came up with on my own is kind of a development of educational empathy over the past 20 or so years. And it's important because in the 1990s, we started with this concept of just culture. The report came out to err as human. We had in the late 90s, we got the 6 core competencies from the ACGME. And then in 2013, the next accreditation system, clinical learning environment, and milestones. And to me, there's an underlying theme along a lot of these, and that's analyzing your student or healthcare worker and looking at their mistakes to improve patient outcome, but not only that, to improve their lifelong learning. It's important to keep in mind that this isn't only for medical education, because a lot of our medical education is occurring in our everyday work. So our constructive versus destructive feedback is not only for education, it's for the workplace, it's for a lot of things in life, but it's important because your medical students or your residents will see the way feedback occurs between an employer and an employee. And this is a concept that's talked about in the business literature. This isn't, I would say, a great piece of business literature, but on Fox Business News, this is an example of how to deliver feedback to employees without squashing morale. And it's interesting, within this article, they say something that's really true and hits home for medical education. Whether positive or negative, feedback should be motivating and constructive. How you deliver this message can help fuel forward momentum or stall any progress. And that's really the truth for medical or resident education as well. When it comes to feedback, I like to look at it as, everybody has a frame that we decide and do things in life. And, the student will have a frame, a cognitive positive frame or a negative frame. the mentor or the teacher will have a frame, positive or negative, the way they react to things. So you might have a picture, but there really might be two different images on this picture. So this is an illusion of a woman. It can be either looked at as an old lady or as a young lady. And just in the same way, any feedback situation that you have can be handled in really a constructive way or a destructive way. And there's no parallel between old lady and young lady and constructive and destructive. So, feedback is designed to influence, reinforce, change behaviors, concepts, and attitudes. So obviously we can do that in either way, constructive or destructive. So what is constructive feedback? It's specific. You're going to tell the student, the resident, it's specifically what they did well or what they did not do well. It's a safe environment. There's no threats at all. And it's non-judgmental, or even better, there's a concept of good judgment, which we'll talk about in a second. And it's conversational. When you make it a conversation, your students or the mentees will internalize your feedback much better. So an example of non-judgmental, constructive, safe feedback would be, let's say there's a contrast reaction in the CT scanner. Kurt, I was so impressed the way you handled that contrast reaction. You were poised, calm, and professional. You knew your ABCs and immediately established yourself as a leader. But we have to review your familiarity with the crash cart. You really made me proud. In this setting, the student or the resident who's listening knows that the teacher is the content expert, but they're going to focus on the but. And they're going to forget about everything else, all the positive things you said. And it's not a bad way of doing feedback. It's an easier way of doing feedback, but it's not exactly the best way of doing constructive feedback. If you just twist things a little bit, so the same scenario, and instead of using that but statement, you said, I noticed that you looked at the crash cart for a few seconds before you acted. What were you thinking at that point? So it's a subtle difference. This would be more considered good judgment in a constructive feedback situation. Here, the student is going to look at the teacher or the mentor as a cognitive expert, but they're going to also look at the teacher as, you know what? They value my opinion and my thought process. They value that my opinion and thought process made me behave in a certain way, and there's a better chance of internalizing the feedback. So what's destructive feedback? Destructive feedback is general. You did a bad job. You did a good job. It's usually in a conflicted environment. It can become sarcastic and harsh. And sometimes at a certain point, it can become judgmental on a personal level. So an example would be, in that same contrast reaction, Kurt, what were you doing fumbling around the crash cart? Time is of the essence. The patient could have died. Or, let's say you're in the middle of a class trying to talk about the contrast reaction. Can anyone tell me Kurt's critical mistake? Something that I've noticed by reading some of the literature and also just observing people is that, again, if you go back to the frame of the individual, whether it be the student or the teacher, when it comes to feedback, lots of times the frame of the teacher or the program director will be more of a frame related to frustration. And that kind of destructive feedback, I think, is a lot more common where there was a medical error and something significant happened, and the program director or the teacher or the principal is frustrated with the situation and it's an emotional, tense situation, and the situation gets the best of themselves. I would say more often than not, that's what happens. But there are people who feel that destructive feedback by design is appropriate. And these are people who are authoritative. They think that using a sledgehammer is the best way to affect change. It will affect change, but there's a lot of consequences with it. And just as a curiosity, anybody have seen this kind of destructive feedback in their, I'm going to say in their lifetime? So it really is a common entity. And it's interesting because last month there was an article, Bullying in the American Graduate Medical Education System. And this article, they surveyed about 1,800 residents and fellows, and 48% reported being subjected to bullying or actually observing some kind of bullying action. So we always talk about bullying nowadays, in the media in high school or on the web. But bullying occurs everywhere. And in reference to graduate medical education, what did they define as bullying? So they said unjustified criticism, humiliation, destructive innuendo, sarcasm. And they actually showed that these residents and fellows said a good portion were coming from attendings and nurses that were above them. And this really goes along the lines of destructive feedback. So what are the effects of destructive feedback? They really combine short-term and long-term. But initially, when somebody gets destructive feedback, lots of times they feel fear, anger, or tension, and this could last for a few minutes, hours, days, weeks. It can turn into a bigger situation of poor self-esteem and loss of self-confidence. Lots of times people are going to not want to ask questions because they're just not going to want to get their head bitten off. They won't know how to deal with the same kind of confrontational situation, and there could be demotivation. The long-term effects of constructive criticism, if we're giving negative constructive criticism, it helps the learners to reconstruct their knowledge. They want to get better. They want this lifelong learning. They want to change and enhance their performance. And if it's something that's positive, that they did well, it reinforces good practice. So last year, Dr. Rawson was speaking about the milestones, and he titled it Making Lemons into Lemonade. And I really think that should be our mantra with respect to feedback, because most feedback situations will feel like a lemon, but it's the way we handle the feedback that can produce it into a lemonade and allow our students and residents to benefit from it. So just a few fine points on constructive feedback. You want to make it an everyday occurrence. More often than not, most of us give feedback when a situation arises. When the recipient hears that, they already get on the defensive. If you make it an everyday occurrence, it's more natural. Again, we spoke about it being objective and good judgment. At minimum, you want it to be non-judgmental. Again, making it good judgment feedback is a little bit of a talent that requires time. It has to be specific. We've got to remember that feedback is a conversation. When you make it a conversation, then it's going to be more meaningful. You want the student to reflect on the situation. You want it to be a two-way street so that the student can actually start asking you questions about the situation. So you want to say, this is what I saw. What do you think? Just a couple others. You want the feedback to be immediate. Sometimes it's not possible, but when it's possible, you want it to be. You want to limit to 1 or 2 items so that the student can actually remember. You want to make it real. You want to show them how to affect change in their everyday life. You want it so that they can internalize it. And one thing that I think is important is everybody wants to defend themselves when you give feedback. If you explain to your student or the recipient that it's a normal response to be defensive, but let's look at the bigger picture of trying to improve yourself and a lifelong learning type of situation, I think that will help them be less defensive. A couple no-nos, just in summary. You don't want to use general statements, okay? Again, we want to be very specific. You don't want to say, that was well done, because we don't know what that means. Try not to use the word but, because the student will focus like a laser on that area. Again, you don't want to be judgmental, and you want to make sure that you invite the student to reflect. And interestingly, Dr. Lorenko wrote in this ACER Spring 2016 newsletter about feedback, and she wrote that most agree that feedback is critical in medical training, and we all agree that it is. And one important thing that she said at the end, that lastly, a word of thanks goes a long way. You know, positive feedback, one little positive statement that you say to your student or to your resident will make their day, will make their week, and will really help them develop. Thank you. And this is a wild turkey at Staten Island University Hospital, so we have a lot of these. So. Okay.
All right, so this is the last session, so thanks so much for staying tuned during this late Friday afternoon session. Thank you, Harp and Lori, for having me here today. So today we're going to talk about Diagnosis Live. Diagnosis Live, as you know, is a free web-based audience response tool that the RSNA gives out to selective institutions. And the goals of this talk are going to be threefold. Okay, so we're going to elucidate the role of audience response tools in promoting resident education. We're going to identify the latest innovations that RSNA Diagnosis Live has to offer to institutions as an audience response system. And we're going to create team games using Diagnosis Live through a demo. Okay, so the first thing, so why do we care about this? Why is this so important? Why are we always hearing about audience response systems, audience response tools here at pretty much every meeting that you go to, whether it's RSNA, AUR, ARRS? So what's our goal? Our goal as educators is to increase retention of learning to our trainees. And if we're not doing that, then quite frankly, we're not doing our job. And I know that everyone in this room takes education seriously because we're all program directors, essentially, right? So this is an important thing for us. And the goal really is to engage residents in learning. And how do we do that? We do that through various ways. You know, there's ways where you can do, constructive, feedback, and audience response tools is just one way to engage our learners and trainees. So, there have been a lot of studies that have shown that, audience response systems increases learning and, over passive didactics. Traditionally in radiology, we have case-based conferences where, one resident assumes a hot seat, and while there's no substitute for a hot seat, and I'm not saying that there's any substitute, some residents can be prone to sort of tune out and zone out while one person is taking a case and everyone else sort of falls asleep. So we've all experienced that. We've all seen that in conferences. Audience response systems is unique in that every resident remains engaged during all the cases that one is shown because everyone is forced to answer a question, right? So you have a PowerPoint presentation, you have a multiple choice question, and everyone has to respond to that question. So everyone is thinking critically and analytically about the questions, and that's the goal. We want our residents to think critically and analytically about the cases that we show. So the latest innovations with RSNA Diagnosis Live. So RSNA Diagnosis Live is now available to 50 institutions. So I was actually quite surprised to see that only one or two people raised their hands because it's actually in a lot of institutions now. Dartmouth is one of 50 institutions that has Diagnosis Live. But it is free, and we'll talk about that later, how to get that. But the things that are available in RSNA Diagnosis Live are, multiple choice questions, which pretty much every audience response tool has, right? So whether you're using Nearpod, Poll Everywhere, point clickers, everyone has multiple choice questions. But the other interesting thing that Diagnosis Live has that not many other ones do have are touch-based questions. So pretty much in real time, and you'll see how this works because I'm going to do a demo. But the presentation gets synced to somebody's iPhone, iPad, or whatever electronic media device that you guys have, and you can display a question and you can ask where the abnormality is on the image that you're showing. So pretty much your trainees are going to point to a specific part of the image, and it will show in real time where the abnormality is. So that's a cool sort of question that isn't really, unless you have this technology, you won't be able to have that sort of way to ask the question. The other thing is team learning. So we all know that, teams enhances competition, right? When we have, just like in sports, when you play, when there's a soccer team or a basketball game, team A versus team B, that's going to bring out the best in people. And I believe that's true in education as well. When you have competition and healthy competition, that's going to bring out the best in your trainees because people are actually going to be actively engaged in the lecture. And RSNA Diagnosis Live allows you to have team games as well. The main thing about Diagnosis Live that I personally think, and I have no disclosures, by the way, to RSNA. It's not like RSNA is paying me to give this presentation here, or I'm getting paid at all any monetary funds. But you can track resident performance with time, and I think that is such a powerful tool as educators because you can see RSNA Diagnosis Live gives you analytics based on your resident's performance. So it'll give you a report of all the questions that your trainee answered correctly, all the questions that the trainee answered incorrectly, and the ones that they did not answer. And you'll get all sorts of graphs and analytics about their performance. And that same analytics will be emailed automatically to your trainee as well. So it's not like you're getting this information and the resident has no idea how he or she did. So this idea of analytics is a very powerful tool that Diagnosis Live has that I have not seen in any other audience response tool. So I think that's amazing. And this is just a snapshot of one of my, I did a QA Miss Case conference, and you can see here on the right the setting of teams. So there's two ways you can have teams. One is the Diagnosis Live, the software will randomly assign people to teams as they enter a game, or you can set it up so that each trainee or each participant can pick whatever team they want to be on. Okay, so there's two ways that you can have team games here. This is a slide, a snapshot of the way resident performance looks like. So pretty much this is the way the analytics is. So the green is, so this student here got 32 questions right on whatever PowerPoint they had. They didn't answer 20 questions and 25 questions were incorrect. Okay, so you get this basic feedback based on all of your trainees and how they're doing and what they. So you can actually track deficiencies and track improvement with time. So you can give a lecture, on day 1, and on day 60 you can give a different lecture, and you can actually track how they're doing with time. The other interesting thing, which I didn't allude to actually, is you can tag questions. So if you're giving. You can tag questions as musculoskeletal questions. You can tag questions as nuclear medicine questions, neuroradiology questions, and you can gather data based on that as well. So, how is this person? How is trainee A doing in neuroradiology with time? How are they doing in nuclear medicine? So all that data gets stratified as towards what type of question you're asking. So that's another powerful tool as well. Okay, so what we're going to do here is we're going to actually do a demo on Diagnosis Live. So I know everyone here has an iPad, an iPhone, or some sort of electronic media where they can log into. So I'll give you guys a minute right now, and you guys all have to log in, because if no one logs in, then I can't demonstrate what I'm trying to show you guys. So it's really easy. You just log into live.rsna.org. If you open up your web browser, go to live.rsna.org. You're going to log in with either, if you have an RSNA account, you're going to log in with your username and password, but you don't need one, okay? So I've put this as a public game. So if you have a Facebook account, if you have any social media account will work. So a Facebook account, a LinkedIn account, you're going to use your username and password for that, for whatever social media access that you can have. Twitter works as well. Twitter, Yahoo Messenger works as well. Whatever username and password you use, it will work beautifully. So again, the site is live.rsna.org. You're going to log in. Let's see if anyone has joined yet. So 4 people have already joined. Good. So Harp is in. Excellent. We got 4 people in here. Let me just put that back up there in case for the people who didn't see it. So it's live.rsna.org. We're going to do a really quick demo. It's going to be literally 5 minutes, just to demonstrate how some of these features work. And even when I start, you can still log in. It's fine. Okay, good. So we have 9 players here. Excellent. Good. All right, so I'm just going to get started for the sake of time so we can get everyone out of here. Okay, so this is a demo. So you guys are going to play in real time with the questions that I'm going to ask. Okay, so question 1. I'm hoping we get 100% right here. The question is, are you a human being? A, yes. B, no. So I'm hoping everyone can answer this correctly. So this is practice. We have 15 people in here. 10 people have responded. 11 people have responded. That should be enough. 12 people. All right, I'm going to close the question in 5 seconds. All right. So 100 people got this right. Excellent. Okay, so good. I'm glad everyone here is a human being. Okay, good. So that's how one of the questions works. So I'm going to show you an image-based question. Okay, so this is an image-based question here. Okay, it's based on these 2 images. There's a radiograph. So I'm a musculoskeletal radiologist. So all these are going to be there's going to be 2 MSK cases. Okay, so this is the first case. Notice that you have a radiograph and you have an MR. The MR is a T2 fat-sat weighted image of the wrist. Okay, so those are the images. And the question here is going to be, all of the following are associated, actually you don't even need the images to answer this question, but all the following are associated with negative ulnar variance except, is it A, ulnar impingement syndrome, B, ulnar-lunate impaction syndrome, or C, Kienbach disease? So 1 person's answered. Excellent. 2 people have. Yeah, it means more people are getting it wrong, but that's okay. That's not the purpose of this talk. Okay, I'm going to close the question in 5 seconds. 3, 2, and 1. Okay, all right. So the answer here was actually ulnar-lunate impaction syndrome. So 36% of the people got this correct. Okay, so that's not bad. So this was a case of, just in case you wanted to know, it's ulnar-lunate impaction or abutment syndrome where you have positive ulnar variance. Okay, Kienbach disease and ulnar impingement syndrome are all associated with negative ulnar variance. This is positive ulnar variance, and if you noticed on the there was marrow edema within the proximal lunate as well here. Okay. So this is a case of ulnar-lunate impaction or abutment syndrome. All right, excellent. So, I can also, if I want to, in real time, look at the scoreboard, and it'll tell me that. So team 1 is it's a dead tie. So team 1 and team 2 are both doing exactly the same well. It did, because that's the way I set it up. I could have set it up that you would choose team 1 or team 2 if you wanted to, but for the sake of this talk, that's the way I set it up. And the players, it'll tell each player's score in real time, so we can do all that. Okay, good. So this is case 2. This is the second case. Just to illustrate the way a touch-based question works, I'm going to ask you guys to point to where the abnormality is. This is an X-ray of the femur, as you can see, and there is an abnormality on this X-ray. So point to the abnormality on your phone or iPad or whatever electronic media device you guys have. Good. So most people are actually getting this right. That's excellent. All right, I'm going to close the question in about 5 seconds. Three, 2, 1. Okay, excellent. So the abnormality here was in the subtrochanteric femur. Okay, this was actually a bisphosphonate fracture where you get a focal nubbing or focal cortical thickening along the lateral subtrochanteric femoral cortex. But notice that this slide tells you exactly where everyone put the abnormality. So some people thought the abnormality was along the iliopectineal line here. Some people thought it was along the lateral acetabulum. But most people here, the yellow is where the abnormality is, and the green is, most people did notice that there was an area of focal cortical thickening here. Okay, so excellent. So that was a case of bisphosphonate fracture. But so you can also ask a question. So we had a touch-based question, but now I threw in a question. So the question here is, all the following are in the differential diagnosis for focal cortical thickening, because that's what this case was, right? There was an area of focal cortical thickening within the subtrochanteric lateral femoral cortex for a long bone, except. So stress fracture, osteoid osteoma, progressive diaphyseal dysplasia, or subacute osteomyelitis? I'll close the question in 5 seconds. All right, the answer here was, oh, wow, everyone, that's amazing. So everyone got this question right. Maybe it's too easy of a question, but Camerati-Engelmann syndrome or progressive diaphyseal dysplasia actually results in diffuse cortical thickening within the diaphysis and the metaphysis, okay? Whereas the other ones, the stress fracture, osteoid-osteoma, or subacute osteo, will really cause focal cortical thickening. Okay, so that gives you an idea of that. So with Diagnosis Live, you can have multiple choice-based questions, you can have touch-based questions, you can add questions, and if you want, you can have discussion slides as well. So these are just discussion slides about a bisphosphonate fracture, talking about it, how it's always within the lateral subtrochanteric femoral cortex. It can be bilateral, high association with bilateral causes. So, and if I want to go and track how people did, I can go to the players, see how people did, what their scores were. It ranks them. If I want to keep it strictly team-based, I can go to the scoreboard. It'll tell me that Team 2 outperformed Team 1 by this many points, okay? So it gives a healthy competition. And if I put it in presenter view, I get all the analytics, okay? And then once I publish the game, all the analytics will get emailed to each of you automatically. And so you'll know exactly what questions you got right, what questions you got wrong, what questions you didn't answer, okay? So it's as simple as that. All right, so going back to, so that's the way Diagnosis Live works, essentially. Let's get back into my presentation. Okay, so that's pretty much it, actually. So I hope that what we did here today in this short 15-minute talk is elucidate the role of audience response systems, showing that it's a way to promote active learning and engaging residents during conferences, okay? We identify the latest innovations of Diagnosis Live, particularly, the multiple choice questions, the touch-based questions, team games, and really the analytics. The driver of Diagnosis Live really is the analytics and tracking deficiencies and tracking improvement and that sort of stuff with each trainee with time, okay? And we created games with a demo to show how this is used in real time, okay? So if you're interested in Diagnosis Live, please, you can see me or you can email diagnosislive@rsna.org to talk to the wonderful people at RSNA. Karen Ham is the administrator that really runs Diagnosis Live. You can email her directly, kham@rsna.org. There's Dartmouth was one of the first people that started it, but there's over 50 institutions now that have Diagnosis Live, and it's completely free of charge. It's a wonderful tool. Any administrative problems that occur with it, which are little to none, they take care of it immediately. And it's very easy so I train the faculty at Dartmouth on how to use this, and it's extremely easy, and we have over half of our faculty use this for case conferences and even didactic conferences. And it was really easy to train all of them as well. So I thank you for your attention. If you have any questions, you can ask now or you can email me as well. So thank you so much. Yeah, that's a great question. So pretty much you have to be using PowerPoint 2007 and above for this to actually work correctly. And it's really simple. I mean, if you make your PowerPoint presentation and then you go to the Diagnosis Live website and you just upload it, and within 2 minutes it's already uploaded. And then once you're on the site, then every slide can be converted either to a multiple choice or a touch-based questions, and you do it right there. I mean, people who are not even internet savvy are very easily able to navigate through it. First, exactly. Well, yeah. Well, you would before you give the lecture, you would have to finalize your slides. So you would finalize what questions you wanted to ask, if you wanted to make it like a touch-based question or a multiple choice question, and then you save it, and then you give the presentation just like I did, essentially in real time. Exactly. Yes.
Similar to like Turning Point, where you actually just do it. You do it on the Diagnosis Live website, right?
Exactly. It is similar.
You don't download anything on your
You don't. You don't. You run it off their software, exactly. And you'll get an email too. So like you'll upload it, and then you'll get an email confirmation within like 1 or 2 minutes after uploading, saying that your PowerPoint is now ready to be edited. And then you edit it, you save it, you're done. Yes. Yeah. Okay, good. So those are great questions. So you have to have Wi-Fi. Every site has to have Wi-Fi for this to work because this is a web-based system. Okay, so it has to have Wi-Fi, and everyone who is using it on a laptop has to have Wi-Fi because it's all. Yeah, that's fine. Yeah, absolutely. Anything that has internet access is fine. That's fine. That would work. And your first question was about access. And yes, the answer is that you can set it so that it's only visible at your institution. You can set it so that it's private, or you can make it completely public. Like I made this public. So actually, anyone, because this was public, like people in Scotland, if they were logged on to live.rsn.org, could have actually participated in this presentation. So based on, and it's easy, once you log in, you'll see where the usage is, public, private, or institutional. Yes? Who owns it? That's a good question. So the RSNA does own it. Okay, so the RSNA does own it. So there have been some patent issues with regards to imaging and things like that. But so be careful. I mean, the images should really be yours. If you do borrow some images, you should give them credit for it. But technically, the RSNA does own it. There have been. So yeah, that's all I'll say about that. Yeah.
So that means that they're saving everybody's PowerPoints. So
Well, they're not necessarily. I mean, you can actually delete anything that you put on there. You can delete. So, for example, I can delete this whole presentation after this meeting, and it'll be off the server, and it'll be as if nothing ever happened. But while it's on there, it's RSNA's, and depending on how you set it, whether it's public or private. It depends on. So most of my presentations are really institutional because it's only at Dartmouth because I'm only doing it to Dartmouth residents, and no one except for people at Dartmouth can really see what I'm doing because it's mainly for the residents that are participating in it.
So you can upload it, do your thing, and then once you're done with the presentation, you can just delete it, right?
Yes, you can.